ഇല്ലല്ല nothing nothing nothing. Thank you. അവിടെ തുറന്നു നോക്കണേ.
Good afternoon, ladies and gentlemen. My name is Ruben, and on behalf of Team Dentist Channel Online, I welcome you all for attending this live webinar. It's also my privilege to welcome a speaker, Dr. Shoukat Ali, during this webinar. Dr. Shoukat Ali is a specialist implantologist who has 20 years of experience in dentistry and 15 years of experience in implantology. He's undergone various advanced programs under Temple University, United States of America, and Toronto University, Canada. He has completed his master's from Austria. He is one of the few specialist implantologists who has a dental implantology privilege license in both Dubai Health Authority as well as the Ministry of Health, Sharjah, UAE. We are so very lucky to have a speaker like Dr. Shoukat Ali who can speak the language of both worlds, that is, short implants as well as conventional implants. He's an international speaker and has lectured in several parts of the world. He conducts CME programs in Austria, Germany, and UAE as a mentor and trainer. He's one of the users of multi-implant systems and his lectures shed light on the pros and cons of an implant system, but he never promotes any particular implant system. Thank you, Dr. Ali, for joining us. I now request you to kindly continue with your live webinar.
Hello everyone. Wish you a lovely afternoon. Thank you,
Dr.
Mr.
Shoukat,
Ruben.
please
Yes.
be a little louder. Thank you very much.
Hello everyone.
Thank you very much, sir. You're perfect.
Wish you a lovely afternoon. Thank you, Ruben, for your generous introduction. I owe you a big treat for that. Hi, friends. Is it visible, Ruben?
Yes, sir, it is visible.
Okay. This beautiful photograph, it's taken with a normal camera, not the DSLR quality one. Most of the photographs I am using in these presentations are taken with camera like this, not the DSLR one. And one of my friend was suggesting me to use a DSLR quality camera, and I bought one. Unfortunately, it was not very practical to use, especially during the surgeries. So this is now using only for extraoral photographies. All the photographs, whatever you are seeing, if the quality is compromised or poor, you have to excuse me for that. And if you come across any beautiful photographs, all the credits are to my assistants. Documentation is very important. You can see this slide. Here, this patient has reached me into the clinic for some restorative work on 2012. We have done some crown and bridge work and some other restorative treatments, and finished the treatment in 2012, means just after 2 weeks. Again, he has appeared in 2014, exactly after 2.5 years. So one thing we have to keep it in our mind. Patients most of the time forget to follow our instructions. This time he has come with a dental caries involving the pulp on this lateral, another caries involving the pulp on the central. So root canal is done and perfectly restoration is finished. Didn't come for the crown, and he has appeared in 2018 later with this fractured crown and a new developed dental caries on this lateral. So every time we are motivating for the oral prophylaxis and regular visit and follow-ups, but most of the time patient will be skipping that because of some reasons which is more important to them than the dental care. In the beginning of 2020, again he has appeared. So this time you can see this lateral and this lateral is completely broken. This was already given one post-encore build-up in prior visit in 2017. Unfortunately, now it's out of question. We cannot restore it. This part, okay, I can do some kind of orthodontic extrusion and bring the tooth down and put a crown. Maybe I have to do root canal treatment. Unfortunately, this gentleman, he has come just before attending a big function. He was the chief guest in that function. So he don't have time to do all these procedures. Next, what all I have to do is just remove these both teeth and place to implant and immediate temporization. That is what is done. You can see the bite. So these bite situations, we should be a little more careful. And whenever we are doing implant, planning implant, this is the first thing we used to do, even before sending patient for the x-rays. The reason is, by the time patient finish the x-ray and come, this model will be ready in your office. You can see so many things which you usually miss when you look at the patient's mouth directly. I didn't give a beautiful base for this model because I don't have to do. It's just not to show anyone, just for me to have a look at the model, especially how is the neighboring tooth. Definitely opposite cast is there to see the bite. Here you can see these two teeth, because of the bite I have shown in the previous slide, it is attreated. Because of this attrition, this crown looks already small. What is a big issue in high smile line patients? You can see the margin of this gingiva, lateral, central, everything is in same line. So what is relevant to this finding? The most important thing is when I'm going to place one implant in these laterals, there will be some recession. Some gingival recession will make this margin little more up. So I may have to increase some sort of soft tissue manipulation in this lateral to look the smile even. Another thing is I should make this gum shrinkage to the minimum. So whatever is possible to do that, I have to follow those guidelines when I am doing my implant planning. Here, the tooth is extracted. You may be aware about partial extraction therapy or socket shield. Here, it's little difficult procedure, but it's very helpful, and so many scientific backup, literature backup is there for this procedure. Definitely, there will be a learning curve, and it is time consuming. You can see here the right side, it is in the process of separation of this root. Left side, the separated portion, the partial tooth is removed, and a small piece of root is still kept inside. And there is a protocol to follow when we are doing this socket shield technique. And here later, this portion is also removed. And patient was asking the best implant in this world. How do they select the best implant in this world? Anyone can just Google the top 10 brands in this world, the implant brands in this world. So which one is coming in this area? First is Strawman. So he was asking for that. The best one in his mind is Strawman. So he was asking the first implant among the best category. Strawman, all of us know it's from Switzerland. It's definitely an amazing system. It's almost like iPhone. The iPhone user, they will not be satisfied with any other kind of implants, any other kind of phones. Same way, those who are using Strawman, it is very difficult for them to change the system from Strawman to other. So here, this is rock solid, and implant is placed, healing abutment is inserted. Then you can see I place some bone graft material. This is a synthetic bone graft material called Easy Graft, which do not need a membrane above this. I don't expect all this bone graft to be there and all the soft tissue will be covering in this area. My intention is just to fill that jumping gap if it is there anywhere, and just to cover the area. Even though these outside particles will shed off, I don't have a problem because soft tissue will be coming in that area. Then later, a temporization is done. During this temporization, it's very important. We have to shape this portion and this portion of this lateral, not like a ridge lap. It's almost like a bullet shape. That is to shape the soft tissue architecture. So later I'll be changing this and loading this. Here, one more type of implant from the Strawman I'll be introducing today. That is SLA active. Actually, this implant which I have used here is SLA implant, SLA rock solid. So SLA active means the implant will be coming in some kind of liquid. So it was a secret among these active, uh, whichever implant companies are producing this kind of, it was a secret. This liquid was not revealed to the world what it is containing. Some are believing it's a sterile saline. So tooth is extracted, and you can see this is a hydrophilic surface of the implant. You can see it's already wet, and it will help to faster osteointegration as per the companies and as per some other literature. You can see it's placed inside, again some bond particles, again the same without membrane, and a tension-free suture. Healing cap will hold the entire thing inside. And this rock solid family, it's containing 15% zirconium and 85% titanium. So we'll be getting the advantage of both world, the titanium as well as the zirconium. They have a separate zirconia implants. If we have time, we will be coming to that later. So here you can see a small line. I don't know, it's visible. Stronger bone responses to the SLA active surfaces compared with the SLA surface. But this part has to be kept in mind. This stronger bone response is limited to the first few weeks. So after that, it must be same like any other implant. Is it relevant? Definitely, because the first few weeks are very important, and uh, it is advisable. It can be loaded earlier than the other normal conventional implants. You can see scanning electron microscope, both SLA surface and SLA active surface. Here, nanostructures can be observed, and at the SLA active surface, that means it is not just a saline immersed implant. Something else is done on that surface. So here we have so many questions coming into mind. Am I conducting this webinar or participating this webinar conducted by Dentist Channel Online to promote one particular brand? You'll be getting the answer while you go through the next slides. Here I am minimizing this one for showing you one video. Any implant, these three factors are involved. There will be a good dentist, an implantologist, and a patient, and a good implant system. You can watch this video. This case is done by one famous prosthodontist and sent to me when the implant was failing because he was out of session that time. So this patient has come. You have seen the implant. I have just removed it with my finger. Here, the issue was not with the implant, not with the surgeon. Issue was with the patient. We don't know what all crazy things these people do with their newly fixed teeth. He was checking whether his tooth can exert more than 45 Newton centimeter force on that implant which doctor has placed. He was always making this bite and checking that one, the integrity of that implant. And finally, that implant has come out. I sent back this patient. After a few weeks, same implantologist placed same company of implant in the same place. And I was the one who was restoring it. And it worked very well, beautifully without any issues later. So the problem was with the patient. Next slide. Patient is normal, a good cooperative patient, and same experienced doctor. This time, this implantologist happened to be a periodontist. He was done from another place, and the patient had issues when they reached in UAE. I know this periodontist. He's very famous and very good doctor. I know him more than 20 years. So the issue is not with this doctor. And patients, all the systemic condition, everything was favorable. But I know this implant system. I have seen, I never used this one. I have seen so many failures in the same implant system happened. You can see again in this another video. This also shoot from my clinic with my beach camera. So the quality, you have to be excused for that. See, this implant again, it has come out. You can take it with your finger. So the problem with the implant, we cannot tell the patient, it was not my mistake, it was not your mistake, it was the mistake of the implant, because they don't expect anything, any cheap alternative or copy type of things from our practice, even though they may be little negotiating for the prices. Ruben, can you hear me?
Yes, sir.
Ruben, can we have a poll?
Definitely, sir. We can have a poll. Can you please
So,
explain the poll?
yeah. So you can see so many implant systems in this display. So what I want you to do is, Can you see the implant which you have, which you are familiar and which you have been using in your practice? At least one implant from this. If it is there, please mark yes, and we'll be evaluating this at the end of this.
Thank you very much, sir. Dear participants, please comment in the chat box. Dear participants, please comment in the chat box. Thank you very much.
Well, so we'll be moving to the next slide. This is Implant Direct from USA. Most of you may be knowing Dr. Gerald Niznik, and one of a famous prosthodontist from Canada. And I'm a big fan of him because he has come up with a strange idea of selling implants directly to the doctors. And that has reduced price without compromising the quality. And because of him, so many implant companies in this year has reduced their price. You can see this implant. They have a beautiful internal hex, and a part of the implant which is completely inside the bone is with a check coating. And here you can see the threads are very friendly for the crestal bone. If this was not a good implant, I couldn't have used it in this scenario. You can see the patient's ridge. This condition is very poor. And when I open, you can see this very thin ridge. And this procedure is done in 2013. So 7 years follow-up, no implant failures, no bone loss, no issues. You can see I have done a lot of augmentation, soft tissue augmentation, hard tissue augmentation, and build up everything along with the implant. This is a not everyday picture. When we do bone grafting, we may not get the result in every cases. But when we get some cases, we definitely will never forget that. This is one among that. Luckily, thank God, there is enough bone, enough soft tissue, and the implant, it was there inside the, you can see the beautiful emergence profile, the soft tissue shape, and even though the angulation is compromised, I could restore everything without much issues. And luckily, the technician was also, he also done a beautiful job. So here you can see the pre and post OPGs. All the implants are properly placed and no bone issues at all. So the question is, if I am getting this result with a economic implant, do I have to go to the first implant, the most expensive one in my practice, which I have shown you? There is the trick. By the end of this lecture, I'll be giving you 3 tips to find out which work, which will not work. This is another implant from USA, same like Implant Direct. The previous one was also from USA. You can see they have come up with a laser lock technology. 8-micron channels designed for soft tissue attachment, and 12-micron, it was towards the crestal bone. The other was towards the soft tissue area. And the most important, again, internal hex, same like Implant Direct. And this area is very strong. By the end of this slide, you will see when I'm comparing that strength of the implant at the neck. So BioHorizon is one of a good brand. If you Google top 10 brands, this will be coming at fifth place or maybe sixth place. This patient has come and his plan is to do implants and overdenture. Later, he will be going for a fixed alternative after adding few more implants. So here you can see upper and lower ridges and OD secure abutments in place after the implant is placed. This is a low profile abutments. When you compare to the locator abutment, this is also produced by zest anchors, same like our normal locator abutment. So later stage, I'll be placing another implant here and on the top another implant here and few more additions on backside. So that's why whenever we plan the implant, we have to look at the future. Here I have placed the position A, B, D, and E. The position C is kept empty. So later I can put one easily and remove all these abutments for overdenture. Then I can make a conventional normal with a fixed uh, denture. Yeah. So this is a previous, this is after the treatment. Here, when I take the OPG, one of the doctor was asking a doubt about this position of this one, whether it has pierced the bone and entered into the nasal cavity. So taken another OPA to confirm it is not, just angulation of the OPG was not right. So here you can see pre and post. So this worked very well and patient was very happy. Overdenture is placed and he is waiting to come after Corona days for placing few more additional implants and fixer prosthesis. Now, I have introduced 3 implants. The common thing about all these 3 is these all are conventional implants. We always discuss everywhere. We have attended a lot of lectures. Now, the next one is different. Different in the sense the entire implantology lessons are different from these conventional implants. This was the implant I have got first exposure in 2005, 15 years ago. So after learning this implantology, I knew only this system, how to use it, and I didn't know anything about our conventional system because I will give you an analogy. Most of you are writing your mother tongue in left to right. When you are exposed to Arabic, it will be very difficult for you to start writing from right to left. Somehow you learn it, same way I have learned it. And you started practicing that one. Then one fine morning, you are exposed to Chinese, the ancient Chinese will be writing from top to bottom and reading from right to left. So everything is totally in a different world. Same way, when I am talking about this implant, short implants, Biocon, 7 years, this was the only implant I was knowing and I was able to place. Then in 2012, I met Dr. Suhail Hussaini, the mentor and the person, amazing person. He was there in 28th. He was there with the one webinar. Anyone can access that webinar. It has to be uh, watched, worth watching. It's there in the YouTube channel. So he was teaching me, holding my hand from 2012 onwards, the all other implant systems. So every time when he was speaking Arabic, I was getting Chinese, or when he was speaking Chinese, I was getting Arabic, because the Biocon implant system, if you see the system, it says short implant. When all other systems are talking about the long implant, they are talking about shorter and shorter and shorter implants. And the surgical procedure, when all other implant system insisting you to use saline irrigation throughout the procedure, and if possible, cool saline irrigation, not to develop any heat in that bone area when you drill, they are against that. They are against the high speed. They are against saline irrigation because they want to take that bone without going into the drain. So it was without irrigation. And when all the implants were screwing and inserting, this was placing with the hand or maybe with the mallet and chisel and one same like osteotome, mallet and tapping. All implants are using a screw and talking about 30 Newton centimeter tightening or talking about some ostal readings. This implant doesn't believe in primary stability. It is not going inside by screwing. When all the implants use abutment with a screw, they don't have a screw. It is just friction fit. So everything is completely different. One is talking Chinese, the other is talking Arabic. So the missile coming behind me is a representation. When I'm presenting short implant among the other groups, every time I'm getting so many missiles from different angles. When I'm talking about the other system among Biocon short implant people, same thing is happening there also. It is two different science. You can see a small implant, short one, I am placing into this gentleman lower arch. Already two are there inside. These implants are made for subcrustal placement. Here you can see the implants are in place. Every implant system is talking about annual crustal bone loss. They are talking about annual crustal bone gain. That is a difference. One way uh, I can show you so many X-rays from my practice, even though I don't have much experience, just only 15 years. There are excellent presentations we have seen from about this one from different great personalities in implantology. You can see here the abutment is not having any screw. It is just going to place, it's in the place with the friction fit. So you can see the soft tissue all around this, beautifully maintained and a beautiful lab work. Thanks for my technician. And here comes the next implant. We are constantly searching which one will work perfectly, which one is more economical, and which one will not survive the test of time. So here come Myriad. It's again a beautiful system. It's from Netherlands. Recently, this company has bought by Straumann. This patient has come for extraction and implant placement. While looking at the patient, it's a straightforward case. Most of the time, this happens. There will be surprises inside when we look at the OPG or the X-ray. You can see Here is my tooth for extraction. And here one hero is laying down upside down. Another one is sitting completely inside. All these are inside the bone. So I have to be very careful when I do extraction and implant placement in this place. I should not wake them up from their sleeping position, or it will be a disaster. I will have to go for a big surgery after that. Here you can see after the extraction, I was very carefully drilling on the mesial side. Implant is placed on the mesial area, and the remaining area is filled with a bone graft. Again, you can see the first day itself, it's a single stage surgery. I was using a healing cap. Why I am showing this one, selecting this implant in this scenario is, this implant is having a beautiful, a wide healing abutment, which can hold whatever we keep inside almost all around. That's one reason. There are some other reasons. When coming back after finishing this series of implants, when we analyze each and every one, you will get that. So here you can see before loading this implant, I have taken another X-ray, and that one is showing all this implant is covered with bone. All this tooth is covered with the bone. So new bone formation is successful. So I don't have to worry about uh, giving an issue, periodontal issue, or other issues for this inside tooth. It is totally asymptomatic, and uh, we don't want to disturb that. We don't want to remove that. Here you can see just before the abutment placing, just before the impression, this is removed. You can see the soft tissue drape come around all this area, and abutment is placed and crown is fixed. Again, I was discussing about importance of making a model before we plan the treatment. The first model, when we plan the model, keep the model together, we will get exactly where I'll be putting my crown after I place the implant. Here, one of the reasons why I was going mesially is because of this tooth. This tooth was coming and hitting on the lower gum already. So I cannot make a full proper crown for this molar. So my one idea was to keep everything away from the inside uh, impacted teeth 7 and 8. The other one was to guard this one from hitting my implant and disturbing the occlusion. So again, you can see if this beautiful soft tissue we get, that means everything inside is perfectly in place. Thank God. If we get this one with an implant system, do we have to go for another one? Do we have to go for searching which other one will be better? We will reach into that. You can see after loading and post loading follow-up x-rays, everything is properly formed. All the graft material I have placed is converted into, or maybe at least radiographically uh, sh uh, showing like converted into a new bone. And here you can see the bone at the margin of the implant is intact and perfect. That's why the soft tissue, which we have seen in the photo, is there in the place. So this is from Italy, the second best implant from Italian market. And I will show you the soft tissue. Again, if I get this soft tissue result, then other than Sweden and Martina, I don't have to look for any other implant. This implant is taken from is coming this way. You can see the neck of the implant is showing like machined collar. Is it good? I don't think so. But they are explaining this not machined collar. They are calling it ultra thin threaded or micro thread surface. That means in case the bone settle down, the soft tissue will not have a problem uh, with the accumulation of plaque later stage. But nowadays we are concentrating on an implant which we don't expect to uh, have bone loss from the crestal margin, and we don't expect that to expose into the oral cavity and plaque accumulation. So this is a good thing or bad thing. That is up to you. I will show you the radiograph. This case, one advantage of this case, I have to mention that. During one implant case, I was planning to do 6 implants. I did all the 3 on the upper. It was little lengthy procedure, and 2 on the lower. And one molar was left behind. Incision was done. Patient said, "Doctor, I am tired. I don't want to continue today. I will come day after tomorrow or tomorrow. We will continue then." I told him, it was her. I told her, "I will finish this implant in less than 10 minutes. If that is okay for you." She said, 10 minutes, half an hour is not a problem. And I have finished it in less than that time, that promised time. Because of the surgical systems they are delivering. It's having stopper, and the system is amazing and beautiful. So you can do it perfectly, precisely, without worrying about the vertical length, especially when you are dealing it with a lower arch, molar area. So there are so many plus points with this implant. You can see extraction and implant placement. Someone may be criticizing this little radio opaque area here, why I didn't use a bigger implant or why I didn't go a little more deeper inside. The reason is I am afraid about this angulation of this canine. So after cleaning, I have placed my implant, and this, what is going to happen to this little radiolucency will be clear from the next slide. That radiolucency has gone. The new bone filling has happened. There is no issue with this neighboring tooth. And this happens most of the time when we follow the extraction socket. If we don't follow the extraction socket, sometimes we will not be able to place same typical kind of tooth in the future. So I was following this one, and when I was making the crown, it was almost same like natural normal tooth. Here you can see the healing abutment in place, and when the healing abutment is removed, you can see beautiful soft tissue. This bleeding soft tissue indicate there is hemidesmosomal attachment of this soft tissue or this area to this healing abutment. That's a good thing, definitely. But the next slide will show you some surprises. We were avoiding these smooth collars because we are afraid of shifting this bone just to under to that area. So you can see some radiolucency here, but it is not shown anywhere in these future photographs, or clinically it is not shown. And there is no issue with the soft tissue. Everything is perfect and fantastic. So this collar will cause some kind of bone resorption during the biological width formation? That's a question I didn't get answer because another same case, a same scenario in another patient, I was placing same implant and I didn't have a problem. And so many implants, I don't have that problem of shifting this bone. So I I was partially believing they are giving a micro thread, not a polished collar. Another thing is after introduction of this osteodensification into this implantology, they you may be hearing some of their lectures. They are not much worried about the surface. If there is little polishing around the collar, they are not much worried about that because whatever they are looking is at the bone side, not the implant side. So some of the presentation they are uh, putting their argument. The old brain mark failure implants were all the machine implants were the reason of they avoid looking, they miss looking at the bone side. Anyway, some literature is supporting, some are not supporting. So we always go through the safer side. This is one of painting, oil painting I have done a few years ago. And the painting was on the wall for quite long time. When my daughter Fatima was small, one day I saw her looking at the picture and she was standing still for quite long time. So when I reached to her, she was asking me, Uppa, can you take me to this place one day? Actually, this is not a very great painting. And this painting was not done looking at any place. There is no such place. It was just from imagination. But when somebody is admiring, and maybe she may be knowing it's just a painting and not done looking at a place, but she was appreciating. And even though that's a small thing, that has given us some pleasure when somebody is admiring or appreciating our work. It is giving, even though whatever smaller way it is giving a lot of happiness. This one is such a small happiness. The root implant, it is from Switzerland. Actually, I was buying this implant just to use as some temporary implants in between my big procedures, full mouth cases. When I cannot directly load, I was planning to place this here and there and put my temporary denture or temporary work uh, on that implant. So when the Miss Amanda came to me with this one, I was explaining to her about my plan. She has given me one implant, two-piece implant. She was just tightening with her screwdriver abutment to the implant and removed that screw and given me. She told me, doctor, try to separate this abutment from this implant. I was trying all my way. I couldn't do it other than using one abutment remover tool. So this was this is a small thing, but not such a small thing. So here, this is not, I'm not regularly using this because of some other issues, not about the quality of the implant. Here, this patient, he's a 70 years old doctor. He missed his canine with some perio problems. Uh, I cannot do a big bone augmentation, wait few years, few months, then do implant. All he was asking me to do something there immediately because he don't want to go to the practice with that open space. Here you can see it's a bridge. I have a plan to remove this bridge and put some implants, but unfortunately, I have to wait till this Corona period finish. So here what I have done, in this area, tooth is removed from here, and this area, the bone slope I was using to place this implant, and immediately given a crown. You can see it. The implant was placed this way. Later, this neck is bendable. I was bending it little, then placing the crown in the right way. So now the problem is this patient don't want to remove it. He's okay with that one. So he is asking to place same kind of implant here. He don't want extensive surgical procedures. So here I have shown you some implants, and there are so many questions coming into mind. Which one is my best suggestion? Which one is the best way to start with if somebody is starting an implant? We have two options. One is just Google top 10 brands in the market and pick the one coming in the first priority, which is giving good service, after sale service, and which is having proper literature support and research oriented one. Pick that one and practice with that one. The second option is learn each and everything from the neck, from the surface, from the abutment connection, and each and every part of the implant about different systems, and pick which is more suitable into your practice. So the second way, when I finish this, I hope when I'm finishing with my three tips, I hope you will be able to go to the second one, means study the implant and select the implant. Here you can see four different implants: BioHorizon, Pseudomartina, Myriad, Implant Direct is in my hand. When you look at this abutment to implant connection, everything is perfect. These all are placed without any screws. Just I have placed it. Once the screw is tightened, that area is completely sealed. Here in Sharjah University, we had a study. The study team, they have collected all the implant available in the market and all the copy and cheap alternatives of those implants. And they were checking the abutment to implant connection, that point under the microscope. So everything was showing very, very small, minute gap, all the brand one. But the copy one, it was showing, everything was showing more than 100 micron gap, which may not be visible to our eyes, but which is a big open door for the bacteria to enter. And this can lead to bacterial influx. That micro gap is not in one dimension. We have to think about three dimension. It's lateral this way and it is vertical this way, all around this screw. So what is happening? Just excuse me 1 second. My land phone was not off. So here you can see the abutment to implant connection. You can see this abutment to implant connection. And this micro gap was able to take bacteria all the way inside. Ruben, can you hear me?
Clearly, sir.
Okay. So this bacteria, whatever is going inside, will colonize there and it will cause crustal bone loss. Along with this micro gap, if it is very small only to go the bacteria inside, the bacteria will go and come out. But if it is little bigger, continuous biting force will move this implant here and there. So once it is moving this side, that gap will be open little more. Once it is out of the occlusion, it will be coming back. This influx and pouring out bacteria will continuously happen throughout the years, and it will cause a problem in the bone. Sorry, you have to excuse me one more second. This is familiar with everyone nowadays because all are at home and all the study sessions are going from home. So some surprises happens in between. So that influx can give some marginal bone loss and implant will be exposed
Excuse
to
me,
the
sir.
oral conditions. Yeah.
Can you adjust your mic?
Yeah. Is
Yes.
it okay now?
Yes, perfect.
Okay. So that is a regular finding when we are using these cheap alternatives. Why this is happening? Why can these copy or cheap alternatives cannot make that precise one like the branded one? I'll come to that after a few slides. Here you can see few literature documenting about the bacterial flow in and flow out and crustal bone loss. I'm not going deep into this. This is available from so many literatures freely from Google Scholar. This is the area these Bicon implants are playing a major role. Their connection to the implant, you can see the implant, how short it is. It's a very small, short implant placed subcrustally. Almost half of the implant length is placed inside. And you can see the bone formation without any issues above that one. This is before loading. Then even after loading, it was successful. And these are the two great personalities, Dr. Professor Jihad and Dr. Vincent. He is the owner of this Biocon system. So they literally avoided all possibilities of bacterial inflow by keeping this abutment tight into that implant well. So that area, it is sealed perfectly with a cold welding mechanism, and literally it is acting like single piece. How this happened? Old dentist among us may be knowing how we use gold foil to fill the cavities. These two gold pure pieces, after removing the oxide layer, when we put together, it will be cold welded and become like one single piece. Same mechanism. Once this is inserted, the oxide layer will be removed by that friction when it is going inside. Once it is in place, it will be acting like one single piece. And the sloping shoulder, they have come up with this sloping shoulder. After a few years, it was called like platform switching in other implant companies. They have changed their shape of the implant and made these platform switching into their system. And that is actually coming from this one. So that sloping shoulder is holding the bone above the implant. And literally, there is no gap for bacteria. Once abutment is connected inside, that bone, when it is getting continuous stimulation, grow above that one. So implant is talking bone gain. Here you can see this implant I have placed very deeper. You can see, looking at this abutment, you can see this is all this deep, more than 3, maybe 4 millimeter deeper implant. Is it giving any issues? Let us see. You can see this one, the soft tissue after I inserted that one into the place, the crown into the place. It is perfect. It's not giving any problem, and very simple. Another case, you can see same Biocon implant, short implant, because I don't have place here to place a normal implant, or I can place it in an angulation, and I didn't want to do. So implant is placed subcrustal, everything is perfect inside. And you can see here the soft tissue formed all around. And the soft tissue around the implant is actually lower than the neighboring tooth. So in that case, why should I think about any other system? Everything I can use Biocon because they are growing bone, they are keeping everything in place. It's not so, because one reason is every case is not a Biocon case. One reason, normally in front area, when there is a deep bite, you may tell that's an issue with any implant. But Biocon, when you use in that position, this removing force of abutment from implant is by holding it and twisting it. That is how we break that cold welding in case if we have to change the crown or if there is any alternation from the treatment plan. So that force will be continuously there in a deep bite case if I place it in the anterior area. How we remove this implant crown from the implant, that force will be continuously subjected in that area. So that area, if you are using a Biocon implant, you may have to attach that one from this tooth and that tooth. So all point of placing a implant is lost there. So that's not an indicated case. Another issue is this one. That patient, the implant was placed. You can see the implant is inserted inside with small tapping. Some cases I can make a proper well and I can place it without any primary stability. Anything, just I can push it inside with my finger pressure. That's enough. But after learning the other part of the implantology, I try to get little primary stability. How do I get it? By tapping it inside. So this tapping is a small thing for us, but it is magnified this way to the patient. Those who are doing sinus lift with the osteotome will be familiar that tapping, how the patient is responding to that one. So fearful patient, this is not an implant of choice. Here you can see another implant. This one is from Germany. Here you can see they have copied everything from the Biocon and copied every plus point from our conventional implant. So mingling this together, all the plus points, they have come up with one implant system. So their connection is also most taper, same like Biocon. And here also this one, after you place the implant, instead of tapping, they are using a screw. Once the screw is tightened into the place, that retention is not depending on the screw. If you remove the screw also, it will be, this abutment will be cold welded to the implant, same leg by cone. Even there is a small guide. This will be helping to insert into the right place. If you cut that one also, this will be staying into the place in proper way. So this implant is also made for subcrustal placement. Some of you may be familiar with the Megagen implant. I have done cases with Megagen, but not too many. So that is also following almost same principle. Their abutment to implant connection is perfect and precise. Why all other companies are not making that one? This is Richard Donaco, CEO of this K3 Pro, this argon company. Here you can see, this is a fatigue testing machine in argon company. Last year, I had a chance to visit their firm, their company in Germany. So there is so many fatigue testing machine. This is mandatory for getting CE certification. So the implant will be placed in an angulation in saline solution with mouth temperature, and it will be continuously subjected to hits. N number of hits will be coming on that. Either abutment is breaking, or the implant is breaking, or the screw connecting implant to abutment is breaking. They are checking that one. And I have seen so many brands of implants, including Zimmer, in their shelf sent for this testing. So this company is testing for other companies and giving them certificate. This many test cycles are subjected to this implant, and fracture resistance is this much, and implant deformation is this much. Then only CE certification clearance will be receiving to that implant. So there are so many things happening behind these brands. That is why I always recommend to go for the brands. Why other companies cannot do all these things? One simple answer is, this company or any company like this, they can produce only X number of implants in a day, because this implant, this abutment, these things should be there in the machine to get that precision. It should be continuously rotating to get that precision for a particular time. So their production is limited. So they can produce only up to this many number of implants. Whereas those who are not looking all this precision, they can make 10 times more implant than these brand companies, and they can sell it and they can distribute it in the market. And by the time we place the implant, we place the crown, and patient has left the clinic. Once if there is any complication coming across, these companies are not there in the market. They already vanished. They sold everything and they vanished. So all what we have to do is tell the patient, remove this one, we will place another one. But these companies, those who are there in the market, they have been there in the market for quite long time. They have a good research group and study circle associated with it. These companies, when you are taking this, they are having a global presence also. So if your patient is moving from one place to another, it's not very difficult for getting these components if there is any issues with the implant. So here, these machines are a good sign. They are the implants subjected to this fatigue testing, and the implant is having that certification is good for us to use. Another reason why I have all these implants in my practice, day for yesterday, Dr. Suhail Hussaini, he was explaining about the implant position, how the implant should be positioned, and what is the border around this implant. So these 1.8 mm Buckley, 1.5 mm from there, 1.5 mm from here, these numbers are easy to pronounce, but very difficult for us to see. We cannot literally see the difference between 1.5 millimeter and 1 millimeter or 2 millimeter. So, but that is very important when we are placing an implant. So when we are in doubt, we have to go with the most accurate one to that particular bone scenario, bone situation. Here you can see this is a strawman. This implant, he is having one diameter 4.1. Their next diameter is 4.8, 0.7 mm bigger. The smaller one is 3.3. So if you have a bone condition which demand little more than 4.1 but little less than 4.8, they don't have it in their collection. While when you go to the Sweden and Martina, you can see the number is 4.25. Their next size is 5 and smaller is 3.8, 3.3. I think 3.3, yeah, if I'm not wrong. Then if you go to the Marriott, they have a size 4.5, 4.1, 4.25, 4.5. There is no much big difference between these diameters. But when we look at that small bone situations, this make a lot of difference. So looking at the bone situation, I have freedom to choose this implant or that implant. Another thing, patients here are from different part of the world. So some people are from Europe. They want an implant which is easily available in Europe. So I can go for that one. Some are from USA. So they want something from USA. So that freedom of selection is also there. But all should be good brand one. This is a simple case. I will show you this one. Just a tissue punch is done and implant is and a small drill is done. Myriad implant is placed and you can see no blood, surrounding area is very clean and the healing abutment is exactly fitting to that. And what is happening there after that, when the patient left to home, she sent me one voice message. I want you to hear this one.
Hi, Dr. Shoukat Ali. Thanks for a short, simple, and pain free implant procedure you did yesterday. Even after the procedure was over, the numbness went off quite fast without much pain. No antibiotics were required. I just took one Olfen 100 mg. The following day was like any other normal day without any pain and good signs of healing and recovery. Thanks, Dr. Shoukat Ali.
So, so I was asking her, can I broadcast this your voice in this my presentation? She said, of course, yes, why not? Because let the people learn if something is there to learn from that. So always we are now not talking about big surgeries and lot of swellings, lot of issues. We are always now concentrating on simple procedures, simple way to go our practice. This is the next day when the patient come, you can see the healing happening here. And as she said, I didn't give any antibiotics and she didn't continue any painkiller. This is another reason why I should have or why you should have different implant systems in your practice. You can see the abutment to implant connection, this neck area. This is biohorizon, Pseudonia martina. This is implant direct. This is Myriad. Myriad, you can see it's very thin at this level. All others are very thick. So if the patient is having very good musculature and if the area is subjected to undergo very heavy force, and if there is any situation like bruxism, I prefer to use something is having a very good, strong, very heavy area in the neck of the implant. So that situation, I prefer to go for other implants other than this one. But so many cases I have done. Maybe this is the most used implant in my practice, and it is very helpful to hold the soft tissue, especially extraction socket, because of that big abutment. And so many references here. I am concluding my short webinar, and it's open for the question answer sessions. Thank you very much. Ruben?
Thank you, Dr. Shoukat Ali. Thank you very much for the lovely presentation. I request you to kindly stop your screen share for a moment. And at the
Okay.
same time, I would also like to tell you the results of the poll. We had
Yes,
about
please.
50% of the participants which voted for Nobel Biocare implant system. About 30% voted for Dentium implant system. About 10% voted for the Ostem implant system. 5% voted for Straumann implant system, and about the remaining 5% voted for Zimmer and Implant Direct. So that was the result about the poll that we conducted.
Okay, good. That's actually not for me. That I wanted these implant companies to hear. Let them do, if it is a cost factor, those who are increasing and keeping the cost away, let them decrease the cost. If it is some other service issues, let the other companies look more for the service. And that's why I wanted this participant to do this one. It is for the companies in the implant market, because so many are there registered for participating this program.
Thank you very much, sir. I'm sure the companies are going to take this in note. Sir, I request you to kindly stop your screen share for a moment.
Yes, 1 second.
Friends, you have about 2 minutes of your time to note down your questions. Please feel free to ask any of your questions related to today's webinar. Thank you very much.
Is it stopped already?
Just a second, sir.
Yeah.
Friends, at this juncture, I would like to introduce to you dentistchannel.online. Today, as you all know, we complete 18 dental live webinars. This has been possible only because of pioneers and stalwarts like Dr. Shoukat Ali and all our other dynamic speakers who came, who gave their time for us. We thank them from the bottom of our hearts and we wish them best of luck for their dental practice. What's more dear to us is all you lovely participants. You all motivate us to keep going. Me and my entire team are working day in and day out only for you all. So I request only for one thing from you, just one simple request, and that is to please subscribe to our YouTube, to our Facebook, and to our Instagram channels. Your subscription will help us in contributing in contributing to the entire dental fraternity for continuous dental education. Thank you once again for your patience. Please do subscribe to dentistchannel.online on our YouTube page, on our Facebook page, and on our Instagram page. Coming to the next part, as you all know, dentistchannel.online is a dental media company. Our sole aim is to continue dental education. If you have a dental case, if you have scientific articles, You can publish it on our platform and let the entire world read. Let the entire world understand what you've done. And let the entire world, like Dr. Shoukat Ali, who loves to share his knowledge with others, we would also love you if you could share your knowledge to the dental fraternity. Because at the end of the day, it's all about learning and it's all about being together. So, if you have any articles, if you have anything related to dentistry, something which is really innovative, something which is technologically advanced, something that is really fascinating, and you wish everyone would want to know and want to learn from that, please do share it to us. Thank you very much. Like I said, please do follow to our Facebook page, to our Instagram page, and to our YouTube page. Friends, as you all know that we are having a high demand for the participation certificates, and hence we decided that the participation certificate would be only given to you upon your request. You can see a WhatsApp number on your screen. I request you to kindly request for a certificate on the below mentioned WhatsApp number. Upon your request, a certificate of participation to a particular dental webinar would be issued to you. I repeat, a certificate of participation would be given to you only and only upon your request. This is about the next webinar. The next webinar would be on the topic See Inside When You Stay Inside, Magnification in Dentistry. Please do register for the same. You can find the link to this webinar in the chat box. Once again, thank you very much for your time and for your patience. It's now time for us to come to the most important part of the live webinar. As you all know, a live webinar is not complete without the doubts. And only with the doubts will Dr. Shoukat Ali be happy that he is satisfactorily able that he could send a message to each and every one of you. On that juncture, I start with the live webinar question and answer session, starting with the first question from Dr. Manasi. Can more micro leakage cause more dental bone loss?
We have different studies. Thank you, Dr. Mansi, for highlighting this point. So many studies are there, and which is showing two way of issues with the micro leakage. Once when the implant is fixed, the abutment is fixed or the crown is fixed to the implant, this we are not living in an open area. This we are expecting continuous force applying onto that. How much force? We know it's 45 kilogram, 90 kilogram, but that is not the fact. If a patient is having one paining tooth on left side and he is having an implant on the right side, he will be continuously biting on the right side only. So that particular tooth will be getting extra force. So if there is micro leakage means these two are
Sir, sir, we cannot hear you. We cannot hear you, sir. No, sir, we cannot hear you.
unmute is okay now.
Yes, yes, I guess you unmuted by mistake.
So up to this time nothing is heard, or should I?
No, sir. Till the middle, you were audible. Could you please repeat
Okay.
the last few lines?
Okay. So the problem is this micro gap means there is a gap. So continuously coming force onto that particular tooth will give micro motion. What will happen to this micro motion? Not only bacterial pump in and pump out, this will be screw loosening tendency for that particular implant. So something is not fitting together means not a perfect one for us to place. So always we cannot take every implant and keep under microscope and watch, because once the implant is open, the seal is open, it is we cannot use it for a patient. So we have to use it immediately, otherwise oxide layer will be forming above that one. So that oxide contamination we don't want to happen. So we cannot open one implant just to check this one because it's a costly one. So we always follow when we buy a good implant from a good market, we know they have done all this job properly for us. So we don't have to do that one. That is why they are in the market. But that we cannot expect from a cheap implant. I hope I answered.
Thank you very much for answering to Dr. Mansi's question, Dr. Shaukat. Moving on to the next question. Question from Dr. Mai Suluman. Thank you, Dr. Shaukat, for the lovely presentation. Are there any guidelines against using implants, such as myriad implants, that have slim implant necks on the posterior area?
Okay, thank you, Dr. Suleiman, for this question. I have done so many implants in posterior area with Myriad. There is no issue at all. But when I have a choice where I am expecting more force, when there is a choice to take this or that, then I select which is having little more thicker, because we know all these are titanium alloys. There will not be much difference in strength. Yeah, there are some implants other than that. For example, this rock solid is having, uh, along with the titanium, 50% ceramic is also there, zirconia is also there. So that difference is there. But still, generally speaking, all these implants are good alloys and almost same properties. So the thickness, yeah, that matters. Even though it is little, that little issue is there. So if it is a very heavy force exerting area, if I have the other one, I prefer the other one.
Thank you for answering to the question, sir. Moving on to the next question. This is a question from an anonymous attendee. How can we decide whether we place implants subcrestally or crestally?
Normally, in our implant practice, everything has to be documented. So the implant placement should be with the X-rays. So when we place this, when we drill, we have a guideline for the drilling. There is a previous X-ray and or CBCT. We know how much is the available bone to drill. We drill it. Then we are selecting implant. We know the length of that implant. Then we are placing it. So if it is not completely inserted into this one, definitely 8 millimeter we have drilled, 8 meter implant we have placed, 1 millimeter outside means it is not completely seated. That may be because of under preparation. When we do under preparation, we should be very thorough with the type of bone we are dealing, type 1, 2, 3, or 4. Because if it is type 1 bone and we are under preparing, we are keep on tightening, either this implant will break or the jawbone will break, because it cannot go inside. There we have to prepare properly to that particular size of the implant. Once it is properly prepared and we know this size is compatible, this hole is for that implant, then when we place it, we are short of, if implant is completely gone inside and we can see little margin outside, that means it is subcrustal. Or when we take the X-ray, we see the shoulders here and there, clinically as well as radiographically. Otherwise, if you place the implant, if you take, just depend on the X-ray, if it is buccal area, normally that area, the slope will be like this. So one thread will be outside. So X-ray will not show that one. So clinically as well as radiographically, you have to observe the site and check where my implant is, where my osteotomy is. I hope I answered the question.
Thank you very much, sir. Moving to the next question. Question from Dr. Prasad. Sir, are there any two-piece zirconia implants in the market? If so, what superior properties they have against titanium implants?
Yeah, that was one slide I missed to present. It was there actually. I was showing the last. There is two-piece zirconia implants from Straumann. Here they are using that implant is stronger actually. Can I have access to that slide? If I can, I would have shown that one, Ruben.
You definitely have access, sir.
So how to do that one?
You
Yeah.
can share your screen once again, and you can go
Yes,
back
please.
to the slide.
So I have to share it from how?
So share screen like the regular sharing that you did for the previous presentation that you showed. Share screen, sir. Green option, the green arrow.
1 second.
There is a green arrow in the footer.
Yeah.
I think maybe, sir, you could explain it verbally.
Yeah, already this is about to come. Just a second.
Okay, sir.
I'll show you. Okay. Anyway, I will explain as you said, because okay, these implants from Straumann, it's a yttria stabilized zirconia implants. So the strength, density, hardness, and modulus of elasticity, these are the things we normally look at when we are talking about whether it is strong or whether it is weak. So here, you know this Vickers hardness, maybe you are familiar with that one. So if you look at the grade 4 titanium, the Vickers hardness is 250. Same time, this zirconia implant from the Straumann, there this hardness is coming 1100 plus. So it is hard. Then coming to the strength, we always talk with the megapascal. So normal titanium grade 4 is having 680 tensile strength megapascal. This one is almost double, 1200 plus. So the modulus of elasticity is the last one, whether it is brittle or not. Again, we consider this one with the gigapascal. So here titanium grade 4 is 110, and whereas the zirconia, this is showing us 200 to 220, almost double. So we don't need something more than this. I hope so. So this is strong enough. Initially, olden days, there were implants, zirconia implants, lot of fracture cases were there. They have improved the implant quality. Same time, if it is one piece implant, zirconia implant, when you use it, you should have a surgical guide, either it is made by you or from a good laboratory. You should, I always advise to use one surgical guide. Some kind of guidance should be there during the placement, because all the limitation of single piece implant is there. When you're using one single piece implant of any other one, like titanium alloys, if it is not properly done, you can trim it and place the crown, change the angulation by trimming it. But zirconia implants, you cannot trim it. So once it is placed, you have to follow it same way. If you trim it, it will be weakening the structure. So there are two-piece implant from Straumann. It's definitely a good one. And some other brands are also there. I'm not very familiar with that. I hope I answered this.
Thank you, sir. Moving to the next question. Question from an anonymous attendee. So, why are few dentists doing n number of cases while others have not started even one case yet?
That's a very interesting question. One of my colleague, she is practicing in Dubai. We have learned implantology together same time. So whatever is given to me was given to her, but she was not doing any implant. And I was, Alhamdulillah, thank God, I am reducing my other practice area and more concentrating to the implantology. So when she was talking to me, I asked her how your conversation start with the patients. So she was telling every patient walking into the room, first they are conscious about the price. So she started conversation even though without mentioning the price, that will be there in her mind when she start her conversation. So keeping something in mind, we cannot talk something else. You got my point. So first you have to believe, think this way, a man having a four-wheeler coming to your clinic for implant placement, and he is going to replace one of his precious part, that is his anterior tooth, that is his personality. See, some people, there are, they don't know, they cannot walk and finish their whole land belong to them in one day. That much property is there. They are worrying about one single implant expense. So the problem is not that one. The way we motivate patients, the way we put that priority into their mind. So first we have to learn this is not a big thing, that I'm not going to do a big thing. I'm not going to buy my Ferrari by placing 3, 4 implants. It is not that. We are taking a responsibility to place one missing organ. And coming to the expectation, what is their expectation? They spend so much, so they want this much. No, we are replacing one organ. Those who lost one leg, they can put one artificial leg. That limb can serve function. So how expensive it is, it will be more suitable to their body. But that is not equal to their missing thing. So these two things, one is about the cost factor we have to remove from our mind, because we are going to do a big job and we are going to replace one organ, and instead of, it's not same like replacing any other organs, this is having aesthetic value along with that. In 80s, we were only looking at the functional aspect of the implantology. 90s, it came prosthetically driven implantology. Now the implantology has reached up to a level. We are in 2000s, we are looking at the functionally, prosthetically, plus aesthetically and biologically driven implantology. So we are giving them something big, not something small. So compare, think that when you are started your conversation, you are going to do a very fantastic job and priceless. You cannot compare that one with some price. You cannot stick some price tag to that one, because every case is different. So when somebody is coming for implant placement, they somehow convinced with our price. When they open the mouth, when we look at that, there is no place for the implant. We have to first build up the bone, build up the soft tissue. So whatever is lost, we have to build it up. So we have to educate the patients. We have to tell them what is the part of, what is the thing we are going to do, what is the remaining thing should come from their side, and what the implant companies will be providing us. So this is a continuous, constant discussion, and patients will not be ready in first visit most of the time, unless you are a very well-known implantologist. So it is starting in a small way. You start to talk to them, gain some tips of marketing tips. This YouTube channel will be having so many, this dentist channel online, their YouTube channel is having so many marketing tips about developing our dental practice. Same thing will be applicable to implantology also. Along with that, I suggest everyone to read a magazine, easy to remember, The Profitable Dentist. They have some good research team. It's continuous. Profitable dentist is continuous. The profitable dentist. If you Google it, you can see their website and all. There are some magazines and some articles are very good to improve our this marketing side and to improve our business. I hope I answered this one.
Thank you, sir. Moving to the next question. Question from Dr. Prasad. What are the loading protocols for Bicon implants? Can we immediately load them if we attain 40 Newton torque?
Okay. Number one, we will never get 40 Newton torque in Bicon because there is nothing to turn. How we get this Newton is by turning something. So we will not get, we will get all what we will get is that feeling. Once it is placed inside, we are tapping into that place. When we take the X-ray, we see there is no gap under the implant and the preparation. There is no gap in between. So we know it's into the place, and it was going with little tight. Yes, I have done lower cases with the immediate loading. Doesn't make any issues. But again, this is not for everyday practice. Biocon is meant to be kept under the crust, deep inside the bone, and let the bone grow above that. After that, we will be having a small tool to trim the excess bone from the top. Then we place this one. But still, there are some good implantologists over here. They do with everything, they do immediate loading, and it works fine. But coming to my practice, I'm not that confident to place Biocon implant and place everything immediate loading. Rather, I prefer if somebody is demanding for immediate loading, sometimes they will be traveling, they'll be just coming for a visit and they'll be going back. After that, there is no implantologist or anyone to see them in their place. So everything I have to finish and send them. In such scenario, I'll be preferring the other implants.
Thank you very much, sir.
Yeah.
Moving to the next question. The question is, sir, my patients cannot afford Strawman implants or Nobel Biocare implants. They can only afford implants such as Dentium or Ostem. What is your take on this?
I'm unfortunately not supposed to comment any brand to take or not to take. We have some legal issues. So I prefer to skip this question.
Thank you very much, sir.
Sorry for that.
Never mind, sir. Moving on to the next question. Does microgap play a role when implant is subcrestal?
Yes, microcap is going to be very dangerous if the implant is subcrustal, because all the bacteria, it will be going inside and playing inside. From that area, it will bring all the bone from top to bottom. So eventually our crown will be outside the gum. A portion of the implant will be outside the gum. But if the micro gap is not there, or if the position is perfect and precise, even under this bone, crustal bone, it's not going to create any issues. Some implants, most of the implants, when we remove the abutment for some reasons, you will be having that bad smell coming from inside. Most of us might have experienced that one. Some implants, their main marketing is there is no that smell from their implants because it is microgap is completely sealed. You are keeping it inside the crustal bone, so nothing is going there, nothing is reaching there. So no bacterial colonization, so no smell, no bone issues. I hope I answered this.
Thank you very much, sir. Moving to the next question. Question from Dr. Mega. Sir, what is the success rate of your short implants, bicon implants cases that you have mentioned?
Dr. Megha, actually, I do not have exact documentation about this, how many implants I have placed and how many failed and how many survived. Or failed I doesn't mean that implant has come out. Failed means either it is aesthetical failure or it is a prosthetic failure or everything is fine, perfect, but patient is not happy. So we have some criteria. So that way I did not document this one. But from this past experience, I don't see any difference between Bicon implant or the other implant. The difference is if I'm using Bicon implant in a compromised bone condition, that is a place where I cannot do bone augmentation. That's a place I can do only Bicon implant without bone augmentation because only small bone, small implant. The problem with that is there I will not get aesthetic crown like the way I build up the bone and I am getting the bone three-dimensionally, vertical, lateral, and everything, and soft tissue above that, then I can give a beautiful crown which was same like or better than the older tooth. But when I am using this Biocon, it's a small implant is placed all the way down, and from there till the opposite tooth, I will have a big crown. So the crown to implant ratio is different. So big crown and small implant. So when the patient opened the mouth, you will see big teeth. That is not with the implant, that is with the situation. So such scenario, you will have big crown, but if it is not visible, most of the patients will be very old. If there is not that much bone, there will be soft tissue will be covering their smile. So again, that is not an issue. So compared to that, if you use Biocon only in indicated cases, and if you use normal implant, you cannot use normal implant without bone augmentation in that situation. So there you cannot compare. But same scenario, if you select this one or that one, both function very well. Both give same result. There is no difference in the success rate.
Thank you very much, sir. Moving to the next question. This is a question taken from YouTube. Can we use immediate implants after extraction of an infected tooth? Which type of implants will suit best in this case?
Very good question. Lot of controversies are all over the world about this one. See, first, when you remove the tooth, you have to look at the remaining bone, not the extraction socket. What is the remaining bone behind that extraction socket? Either it is from inferior nerve or from the sinus. So if you have a small tooth and it is infected, if think about this way, there is periapical abscess or some granulation tissue. You remove that tooth, granulation tissue or abscess came along with that. Then you clean the socket. There are different methods to clean the socket. If nothing is available, just curate it. When you curate it, there is a protocol we always follow. 20 scrapes in every wall. Every wall means there is no four walls. All around, every place your curate should move this way 20 times. So whatever periodontal ligament is there, everything will be come out. After that, you have to use saline, normal saline, clean that properly. After your socket is prepared and very well ready, take a small gauze, dip it in saline and keep it in the socket, wait for 5 minutes. That's will make sure almost the area is perfectly clean. Then you start your drilling. The drill will go to the fresh bone and the socket will be bigger. The implant socket will be bigger if it is possible. Most of the time, mesiodistally it will be bigger, but buccolingually, because the tooth shape is like this, there'll be gap. So wherever possible, increase that one. So bone to implant contact big, that ratio will be more. Implant will be placed into the fresh bone, not exactly on the infected site. It will be drilling more inside. It will be going there and staying there. But this is possible in case if there is enough bone after the infected root. So if it is not there, if it is close to the sinus or close to the inferior nerve, once if you remove it, there is nothing much to do. There is a chance of having some infection inside, and you drill it, you place same kind of implant. Two chances are there. Either it will fail or it will survive. So that is solely depends on your clinical situation. If it is going to be successful implant, there is no issues with the crustal bone. We are talking about the apical area. So if that one way of one school of thought is there is no tooth structure for this bacteria to grow, and implant cannot feed this bacteria to grow. So if you clean it properly, if you place the implant, the area will be properly taken care and nothing will happen. Another issue is when you do that way, if because of some reasons, there are so many reasons which is unknown to us, we place implant in right place, right time, right way, implant is coming out. So there is a chance these patients can talk against you. The doctor has placed the implant into the infected site, that's why it has come out. So the problem when it is coming in front of the court, there will not be enough scientific things to support your argument. So it is always again go through the safer side, because we have enough tension and stress from other things. So we don't want to have from the implant this side also. I hope I answered this.
Thank you very much, sir. Moving to the next question. A question from Dr. Mohammed Abdul Qadir. How is the treatment protocol for atrophic ridges?
Yes, Dr. Muhammad Abdul Qadir. This is a very wide question. Uh, I don't know which part you want me to explain. If it is with a short implant or big implant, or I have to first build up the bone, vertical, lateral augmentation, then I have to go for the implant, or use some cortical implants and finish the job. So it's a very wide area. I don't think I will be answer this. If I get little more particular way, it will be helpful, because I think another 70 plus questions are remaining. I don't know. All these are questions or some are just messages.
Thank you very much, sir. Maybe Dr. Abdul can get in touch with you personally. Moving to
Yes,
the
please.
next question. Question from Dr. Kaushik Mondal. Is rock solid having any advantages in diabetic patients? If yes, why?
Any implant, if you are placing, if it's a good brand, it is having so many plus points. Then coming to this rock solid, we know their surface, we know the quality of the implant, and we know the all possibilities of failure of the implant is less in that system. That way, it will be giving more positive result in compromised cases like diabetic patients. If you particularly ask me, do I have any scientific literature support about this one? I have, but I need to search. If you can contact me through my email, it's implant UAE, very simple, United Arab Emirates, implant UAE at gmail.com, or any other platform. I love to share those articles. Thank you.
Thank you very much, sir. Now moving to the next question. Can we stop or decrease the bone loss around the dental implant by blocking the pro-inflammatory factors?
Yes, definitely. Because bone loss, when we are talking about bone loss, we have to think about not three dimension, so many dimensions. For example, patients' oral hygiene. It will bring down our bone from the gum towards down. I mean, it is starting from top to bottom. If it is other condition like micro leakage, it will bring our bone down from inside to outside. So these two factors, if oral hygiene and if the implant factor is controlled, then we can do whatever possible way to improve patients' immunity or improve patients' health situations. So that all will contribute to the success rate of implant and keeping our soft tissue there, keeping our uh, connective tissue tightly around this neck. Because whenever we think about any systemic situations, we are thinking about this connective tissue band around our abutment or about around our neck or just above the crustal level, because that is the area we have to get a tight band in order to prevent epithelium to grow down, in order to prevent this socket, this attachment loss. So connective tissue is there, epithelium is there just above that one. That is the reason BioHorizon has come up with some laser lock technology even on their abutments. So there, the soft tissue, they are concentrating on soft tissue. So coming back to this, by improving these factors, this patient's health situations, we can definitely improve the situation of the implant.
Thank you very much, sir. Moving to the next question. A question from Dr. K. Sheila. In laser LOK implants, whether only the collar region is laser surface treated or the entire implant body is surface treated by laser? That is the first question. The second question from the same doctor is, what is the type of laser used for the surface treatment?
Sorry, I don't know exactly answer to this question, because first question, yeah, the laser, that laser lock technology is at that collar area, that 20 micron, the 8 towards the soft tissue and 12 towards the bone. But the what type of laser they are using, it's purely mechanical part. Unfortunately, I'm not aware about that, but surely I'll be searching that one. I have noted that question.
Thank you very much, sir. Moving to the next question. Question from Dr. Prince Chaco. As you mentioned in your session, the microgap can accumulate plaque. So why not use single piece implants only?
I uh, I forgot to include one single piece implant. I have used single piece implants. Here, the limitation of single piece implant is once when we place it, we cannot make any alteration in the angulation. If it is titanium, yeah, we can do some trimming. That is one thing. Other thing, to place a single piece implant, we need enough bone, because we have to get proper stability of that implant, because something is protruding out. If it is not stable enough, it will move by patient's normal biting force or tongue force. So that will eventually fail the implant. When it is two-piece implant, this piece, even though the preparation site is bigger and implant is smaller, like Biocon, we prepare bigger site, place the implant with our finger. What is happening there? The implant will be inside the socket loose, and if you check the Biocon implant, you can see all implant will be surrounded by very thick cortical bone. I mean, the implant next to the implant, bone quality is very good. We know we always talk about the bone quality of maxilla is poor. Everyone agree with that. Not like lower mandible. But I always wanted to ask one question. I'm asking that one here. Which tooth you find more difficult to remove, lower anterior or this maxillary first molar? Because even though bone quality is not good, the immediate around the tooth, the bone quality is excellent. We see it like lamina dura, that white area, the very thick, hard bone holding the tooth. So we are not worrying about the whole bone. Instead, we are worrying about the immediate bone, which is near to contact with the implant. So when you place a hole, bigger hole, and place the implant in Biocon, that area in between the implant and that micro gap in between implant and the bone will be filled with a fresh blood. They encourage you to induce bleeding when you place the implant. So that blood will be forming into cortical bone, or a bone which is almost same like similar property like cortical bone. So here the problem is, imagine I don't have a good quality bone, or if it's a good bone, but if I have a very little wider socket, preparation, osteotomy, if I use one single piece implant, that implant will not be stable inside. Biocon is not getting any disturbance because it is subcrustal and everything is inside. So even though it is not having primary stability there, it is not getting any disturbance, no micro movements is reaching there. So if it is a single piece implant, micro movements will be continuously reaching there. If it is more than 100, it will fail the tooth or the implant. So the limitation of single piece implant is there in every case. That is why people are going away from this one, single piece implant. Another thing, the abutments. Again, you have a lot of options in abutment. If you have to place implant little angulation, you have angulated abutment to compromise that one. That is, instead of that, you cannot place an angulated a single piece implant with angulated abutment. Means the abutment part, if it is there, then when we drill it, it will be drilling like not a straight piece. So it will not be going that way. So always we use two-piece implant in such scenario. That is one thing. The other thing, now some implant companies are there, single piece implant, but the tip you can bend little. But the problem with that one is the emergence profile. Now, as I told you, we are more and more looking at the aesthetic part. So there also again, two-piece implant will be better. Thank you.
Thank you very much, sir. Last two questions before we wind up with the live question and answer session. The question is from Dr. Praveen Kumar. Are you conducting any hands-on courses for implants?
We have some programs going on here. You can communicate to me through this implantUAE@gmail.com. I love to answer. Or there are some courses going on here in Middle East. I can guide you to there. I'm a part of that, not directly, but I am a well-wisher of that one because it is spreading the knowledge of implant all over this area. I
Thank you
can
very
guide
much,
you
sir.
there also.
Thank you, sir. Once again, moving on to the last question of the question and answer session. Question from Dr. Prasad. Sir, as you told, no irrigation is used when doing osteotomy for Bicon implants. How is the heat generated dissipated without rising bone temperature?
This is again a beautiful topic I want to discuss. I would like to discuss it, or I love to discuss over hours together. in 2 or 3 sentences, I will answer this. The drilling protocol is different. First drill will be with irrigation, like any other. That's an initial pilot drill. Then after that, we have so many drills. All drills are just scraping the bone in a very low speed, very good torque. It is just scraping the bone. So what is happening there? Every time a small layer of bone will be taken away, you imagine after your extraction, if you use a sharp curette and shape the bone socket, it will never produce any heat. So same way, it will be scraping that way, and along with that, that bone which you are removing will induce bleeding into that area. So always one layer of bone is removed, then you use the next drill, then next drill. Every drill you progress, you are getting fresh blood into that area. So that will be very helpful for the healing also. That is how the heat is not generated there. But you cannot apply that science in our normal drilling area. So that is why I said these both are, if one is Chinese, the other is Arabic. And both are fortunately or unfortunately not our languages. So we have to learn both in different ways.
Thank you very much, Dr. Shoukat. With this, we come to an end of the lovely question and answer session, as well as the fantastic live presentation that you gave to all our participants. Once
Thank
again,
you very much.
friends, just to tell you that you can get in touch anytime, any day with Dr. Shoukat Ali on implantuae@gmail.com. He would be more than happy to help you, to guide you, and to support you as a mentor. With this, we come to an end of the lovely presentation. Once again, on behalf of Team Dentist Channel Online, I would like to take this opportunity to thank you, Dr. Shoukat Ali, for the valuable time and for your knowledge that you shared with our participants. We're very
Thank you very
grateful
much.
for your valuable time. Thank you, friends. Thank you, participants. Please do register for all the upcoming webinars, and also please do not forget to subscribe and to like and to share Dentist Channel Online to all your friends from the dental fraternity. Thank you, and may you all have a good day.
Thank you very much. Have a nice day. Bye.